Okay, so this is going to be your voiceover for your lecture on alterations and excretions for Nursing 2244, which we are going to primarily talk about acute kidney injury and chronic kidney disease. I know this is topics that you actually have talked about in the fall course, but we're going to dive a little deeper into them and how they affect the other body systems with this particular course or this particular lecture. So I did reference ATI, your med-surg book, chapter 61 is where you'll find this information. And since you still have Iggy, that chapter is chapter 60 if you want further um, information on it. Just a real quick review of the basic renal system. You know that we have two kidneys, we have two ureters, we have the urethra that comes down from that. Sorry, I hope you're not hearing my dog. I should have told you at the very beginning, I am trying to record this at home and she likes to bark at the wind, so we never know when that's going to happen. So we're going to start with a little basic review of your renal system. Before I do that, I should kind of caution, I'm recording this at home, which unfortunately for me, I have my dogs here. So if you suddenly hear one of them bark, I'm sorry. I'm trying to keep Bailey, my doodle, quiet. Sometimes it's a little difficult because she barks at her shadow and at the wind and any slight movement of anything. So going back to the renal anatomy, we do have, our two kidneys, which they're positioned on your sides, kind of in that retroperitoneum area, right and left. We have two ureters. We have a bladder that this all feeds down into, and then urethra where we will then discard any waste, excess water, that kind of stuff that the kidney has filtered out. The kidney also, I always say the powerhouse of the kidney is the nephron, because that's really where a lot of the work is done. Your nephron is where your glomerulus are housed, or where you find those. And that's the unit where the blood kind of passes through. That's where the filtering happens. It will pull the excess water that we don't need. It will get rid of all the waste products that we don't need. And that is what then goes down into your bladder and you eliminate from the body. So it's really important that, if these are not working correctly, that's why we see changes in our electrolytes. You may see the patient develop a metabolic acidotic state, things like that. They may have fluid retention if they're not pulling that excess fluid off. As the kidneys start to fail, you can also see albumin be passed instead of being filtered like it would normally be done. Um, so that can also lead to further complications with edema. So just a few things to think about. Always kind of go back, and if you're not really comfortable with anatomy or physiology, it's always a good idea to review that. And on talking about the anatomy and physiology of your kidneys, kind of already talked about the anatomy part. Physiologically, mentioned this briefly in the other slide, they do have very key functions that they help us with. Removal of waste, talked about that. They help with fluid and electrolyte balance because as the body is filtering, um, it will get rid of the excess when it is working properly. That's why you see patients who have renal issues have problems with their potassium being elevated, their phosphorus being elevated. Sodium can be elevated as well, or can be low depending on what stage they're in. Same thing with calcium. So it definitely can affect that. It does affect the pH because if we go back to that acid-base balance, this is the process and part of the bicarb, the base part of that acid-base regulation. So it helps with that acid-base regulation as well. Helps regulate your serum osmolarity. So that also is an important thing that this system does help with. Erythropoietin, which we have talked about, I know before I talked about this in oncology, I've talked about this in PEDS class. That erythropoietin is the little hormone, shall we say, that stimulates your body to want to make more red cells. So that's the thing that when your body gets low, it gets turned on, your body kicks out more red cells. Well, if your kidneys are not working properly, they're not going to be able to produce that and kick it out for you. So sometimes these patients start having issues with anemia, and that may be one of the things you see before you really start noticing that there's changes in the renal function itself. So that's something else that they tend to check in people who are anemic as well. And then we have that renin or renin, however you want to say that, that does help with blood pressure regulation. And that's your renin-angiotensin-aldosterone system, or that RAS system, um, which again is a hormone system. It definitely helps with regulating blood pressure. It helps control fluid and electrolytes. It coordinates effects on the heart, also helps with vascular resistance. So it's a very big thing dealing with blood pressure. And that's why, again, you start to see issues with blood pressure as well. Um, Blood pressure being elevated can severely affect kidney perfusion. So that's something we have to worry about. And then it also does help convert vitamin D to calcitrol so we can actually use the calcium that we consume. A closer look at your nephrons, you can see the structures within the nephrons are things like a glomerulus, and that's found within the Bowman's capsule itself. Resistant vessels, they have afferent and efferent arterioles, excuse me, that GFR barrier, that GFB, and this is all talked about in your module if you want to look at that further. I also know they have a nice little animation on how the nephron works that's for people like me who like things to be moving all the time. It's a good way to kind of understand how this nephron works because it is very important to the function of the kidney. It helps you understand what happens with AKI or CKD, as well as like glomerulonephritis, pyelonephritis, and why that nephron is so very, very important. Like I said, its function is to filter out any kind of waste, and that should be WASTE. I just realized that that's misspelled, waste products, and also to produce urine. So it gets rid of the waste, excess water. That's what we forms our urine, and we excrete that. Um, and so the nephron is really a very important part of this, you know, the kidney itself. I always, like I say, I call this the powerhouse. I was looking at the renal circulation within itself. And I look at this and it kind of reminds me very much of like circulation to the lungs, where it comes in through those arteries, those renal arteries, and then gets filtered down into some of the smaller arteries, eventually entering the arterioles, where it will then go into the nephron and that glomerulus and that Bowman's capsule, where they're going to have that glomerular filtration barrier and stuff going on, where that transfer can take place. And then it will eventually get picked up again through those arterioles, taken into the capillaries, and then it will leave through venous circulation to return to be sent out back into the body, the stuff that needs to be saved, and the waste products will be then turned into urine to be excreted. But I think this is kind of a cool little slide, just kind of showing you how it works. And if you really look at this and compare it to how um, circulation to the lungs works with the alveoli, it kind of makes this picture a little more clearer. This is just looking how urine is processed as it goes through that glomerular filtration membrane. And that's done through hydrostatic pressure, what helps push that through, and it filtrates that blood, plasma, solutes, takes what the body still needs, gets rid of what we don't. We talk a lot about GFR when we're looking at especially chronic kidney disease. It's one of the things we look for in staging it. So that's very important. Normal rate is 90 to 120 milliliters per minute per 1.73 meters. I think that's supposed to be meters squared if I remember correctly. But don't get hung up on the unit. Just know 90 to 100 is a normal GFR. Because that does become important when we're looking at staging our CKD patients. And that's all on a feedback system. So the body will, like I say, it will take what it needs out that the body still has to have, but it'll get rid of anything that it doesn't need. So if your potassium's high, it will try to get rid of that for you. Okay, so it kind of works on that feedback system. We're going to talk just a minute about kidney functions and how that affects your overall health. We've already talked about kidney functions as far as how it removes waste, it helps regulate your fluids, your electrolyte balances, helps with acid-base balance, helps with promoting bone integrity because of the absorption of vitamin D, which helps with the calcitrol, and also hemodynamic stability due to that RAS system, that renin-angiotensin-aldosterone system, which helps to like maintain vascular resistance and things like that. If you look down below in the presenter notes, it talks about that second key concept. When there is an alteration with the cardiovascular system that decreases cardiac output, the proper functioning of the kidneys is also affected due to decreased blood flow to the kidneys. So this is one of those things. When Susan did her first lecture on hemodynamics, I know I've mentioned it several times, we're always talking about monitoring that MAP, or that mean arterial pressure, because anything under 65 means that certain organs are not going to be perfused as well as they need to be. So a decrease in blood flow to the kidney will affect its ability to function properly. That's how people wind up with acute kidney injuries, or one of the reasons they wind up with an acute kidney injury. Probably one of the most common, quite frankly. But once that happens, if you then look at this and I tell you that it's going to mess up their electrolytes, if I already have somebody with a cardiovascular event who now has a potassium of 6.2, now I'm putting them at further risk of issues with their cardiac function because of that high potassium. So same thing if I shift sodium, I'm going to worry about affecting their neurological system. So all these body systems do play into each other. So that's why it's so important that we're monitoring that MAP and checking it before it ever turns into a problem with the kidneys. So looking at some of the lab that kind of keys you into, hey, there's something potentially wrong here. Your BUN, which you guys are familiar with. And this is just kind of measuring those waste products of that blood urea nitrogen. Okay, so you guys are very familiar with BUN. Creatinine tends to be the waste product from breakdown of muscle and stuff like that. Normal BUN is usually 7 to 20. Creatinine, usually you want it less than 1.2 for a female, 1.4 for a male. And then we have the GFR, which we want it to be above like 90 or above. If they're hitting 90, they're getting close to being considered like a stage 1 chronic kidney disease. So because normal is at 90 to 120. So just some things to think about. But I really, really want to encourage you guys to really stop and ask yourself, if my kidneys are not functioning well, what other body systems are going to get affected by this? So now we're going to look at some pathophysiology, looking at severity and stuff like that of your AKI. I'm going to talk now about acute kidney injury. I know on the student version of this, the original pathophysiology, I just had the sudden cessation of renal function that occurs when blood flow to the kidneys is significantly compromised. But after I went back and reread this, it's not just blood flow that can affect this. We can have damage that occurs to the kidney itself, whether that be from like pyelonephritis, glomerulonephritis, some kind of event that's happened within the kidney that's caused some damage to the structures. Or you can see it happen from like an obstruction down below. If you have issues with the ureter having a block in it, urinary retention, UTI, where something travels up, that's going to turn into like an intrarenal problem. But there's more, which we're going to talk about on some of these other slides, whether it's pre-renal, intrarenal, or post-renal. But I just want to kind of add some things to the pathophysiology. But these are the things that lead to the destruction of the filtering ability of the kidney, that puts the patient at risk for this AKI. So the severity is really based on the increase in that creatinine, as well as you start seeing decreased urine output. So some numbers here, things like an increase of 1 to 2 milligrams per deciliter every 24 to 48 hours, or you can see an increase from like 1 to 6 milligrams per deciliter in a week or less. So just some numbers to kind of throw out at you. I'm going to look down at this key concepts. It talks about acute renal failure has a significant impact on disease management for the client's primary disease, which kind of already talked about that. Because if you think about it, this is your filtering system. So a lot of the drugs we're now going to use to treat the problem that may have started this, like they list heart failure or sepsis, um, are going to be affected, those medications are going to be affected by how well they are excreted. I also have to think if I have a patient with sepsis who I'm now going to use an antibiotic for, some of those medications can also affect kidney function. So I'm going to have to be really careful on what antibiotics I pick to use and how much I give them, because I don't want to cause any further trauma or damage to the kidney. So just some things to kind of think about. Also think about these patients maybe having scans done, and we have to worry about contrast dye. So, like I said, I just start putting those pieces together to paint a good clinical picture. All right, so looking at the types or the etiologies, and I've listed that chapter again in IGGI as well as the chapter in your ATI. And that's always going to be med-surg for this particular content, unless I tell you nutrition, which I know there is some information in the ATI nutrition when we start talking about diets. So when we talk about types or causes of an acute renal injury, we're looking at things like whether it's pre-renal, intrarenal, or post-renal. So pre-renal are things that happen before it gets to the kidney. And you can see here that accounts for about 60% of the cases. And this is ARF, which is an acute renal failure. ARF is the same thing as acute kidney injury. So let me just specify that. I want you to get hung up on terms. So it lists here some of the causes. Hypotension, hypovolemia is probably a very common thing. Whether that happens from trauma, think of like a trauma, somebody bleeds out, they're going to be hypovolemic, they're probably going to be hypotensive. Heart's not working well, we have decreased cardiac output. Liver failure as well can cause problems with this. Medications can lead to pre-renal issues. So you've got some of them there. We've got some of them that are blood pressure medications listed there. Intrarenal, the damage actually occurs to the kidney itself, and that accounts for another 35% of acute renal failures or an acute kidney injury. So that's stuff like acute tubular necrosis, and that can happen from nephrotoxic agents like some of your antibiotics, aminoglycosides. You have to be really careful. That's why sometimes you will see them doing peaks and troughs, because we want to make sure those numbers are in ranges that are safe for the body. So we need to see how well the body is metabolizing and excreting those medications. That's why we do those peaks and troughs on patients when they're on certain medications. And then again, things within the kidney, like I think of glomerulonephritis. Sorry about my dog, there she goes again. So those are just some things that can cause it. And then again, looking down at post-renal, and that's just usually occurs from some kind of obstruction in the urinary tract. So I think this could even be a kidney stone that gets lodged in the ureter. It can be caused from inability to urinate. We get backflow of urine, those kinds of things. And that occurs for about 5% or so of your acute kidney injuries. But the most common would be the pre-renal, followed by the intrarenal. And always make sure you kind of look at these key concepts. I like how ATI, I didn't write that particular thing. I got this from ATI under key concepts, but I do like that they point out certain things for you guys to kind of lock onto when it's talking about the content. So this is looking at the classification system, and this is from the Kidney Disease Improving Global Outcomes, that KDIGO system that they oftentimes use. You can find this in IGI. It's also in your ATI book. Stage 1, stage 2, stage 3. So this is looking at risk stage, injury stage, failure stage. And you can see this is all based on the creatinine level. You see that going up as the stages become more severe, and also on the urine output. And I know we have like drilled it into your head. You don't want to see urine output less than 30 milliliters per hour on a patient. But still, if you have a patient who is at risk, you really need to be watching that very, very closely. If you see that urine output going down, 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 you notice that the creatinine is going up, 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 you need to be paying attention. Is this patient potentially at risk for an acute kidney injury? Because if we can catch them at that point, we could do something like a fluid challenge with them, give them a bolus of fluid. It may help kickstart that kidney. Sometimes that all it needs is a little bolus of fluid to tell it, hey, yeah, I got to wake back up and do my job. So, just be familiar with the stages. I don't necessarily plan on asking you, oh, give me the criteria for a stage 3 failure stage of acute kidney injury, but it does make sense. I would be kind of aware, if you're to 1.9, normal is 1.4 for a man, 1.5 to 1.9 is going to be you're at risk. If you look at it, it's kind of nice because then it goes 2 to 2.9. So if they're in the 2s, they're at injury stage. If they go above 3, they're in a failure stage. So it just be kind of familiar just so you understand it, but don't make yourself crazy, especially on the amount of urine and stuff like that they're putting out. You know that 30 mils per hour is kind of your cutoff there. Phases of an acute kidney injury, and this should be review again from what Angela taught you. This is a rapid decrease in kidney function. It leads to a collection of metabolic waste in the body. We've talked about that on these other slides multiple times. The phases are onset, oliguric, diuretic, and recovery, and they will go in that order. Depending on how quickly you catch it, will kind of determine how long each stage is going to kind of last, as well as patient factors as well. Acute syndrome may be reversible with prompt intervention. Like I said, if you are noticing it early on that those kidneys don't seem to be putting out as much as they were, and you know from the history that this patient may have had a MAP that was low, maybe they had a heart attack, had low cardiac output, you may be able to catch this early and hopefully turn this around a lot quicker and preserve that kidney function. So we're going to go over and look at each stage, or each phase, I should say, on some of these next slides. These are looking at the first 2 stages. So you have onset that begins with the onset of the actual event. It ends when that oliguric phase develops. So this usually lasts a couple hours up to a few days. Like I said, you paying attention and catching will help this patient recover quickly. Oliguria, you guys should be familiar with this term. Oliguria means decreased urine output, and that begins when the kidney is insulted. Urine output will fall to 100 to 400 milliliters per hour. And I noticed down in the bottom here, when I originally did this, I have the wrong number, and that will probably be on your student PowerPoint, but I'm going to correct this before I post it. It should be 100 to 400 milliliters per 24 hours, which equals 4 to 17 mils per hour. And that is with or without diuretic therapy, because that's something else they will do when they're noticing urine output is low. They may also give some diuretics to see if we can get the kidneys again to wake up and start putting out some urine. And this can last anywhere from 1 to 3 weeks in that oliguric phase. On to the diuresis phase, and this begins when the kidneys actually start to recover and they're kind of waking up and they realize, hey, I got to get rid of all this excess fluid that my body has been storing since my kidneys have not been working. And so then they will start dumping larger amounts of urine. And this can last for 2 to 6 weeks. This is actually kind of a yay moment in a patient with AKI, because you've been seeing less and less and less urine output, and now you start seeing dump, 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 which tells you those kidneys are waking up and doing their job. And then the recovery phase, which just means that kidney is going to heal itself over time. Hopefully, it will be fully restored. That's what we hope for. And this can take up to 12 months for that to occur. This is one of the reasons we like to be paying attention. We like to intervene early, because if we don't, this patient may not wind up fully restored and actually suffer a chronic kidney problem when we're done. Patients who have chronic kidney disease can still have an acute kidney injury. So that's something you have to be mindful of too. Don't just think, oh, this patient already has CKD. No, be paying attention, because they may be like a stage 2 CKD, but if we don't intervene, they could wind up a stage 4. So you really have to, this is something you always want to be watching for in all your patients. Looking at some of your expected findings or some of these clinical manifestations that you may see. This is due to those waste buildups and decreased urine output. So you may start seeing like fluid volume overload, those kinds of things. So cardiovascular, fluid overload, didn't even realize that was down there. You may see dysrhythmias, again, because the hyperkalemia can cause a problem. Respiratory system, think about if they're in overload, you're going to see or hear crackles in their lungs indicating they've got fluid there. You may see them not able to oxygenate because that fluid is affecting that transfer of oxygen and CO2 at that alveolar level. And they also may become short of breath, especially when laying flat. So they might prefer the sitting up to being more in a reclined position. From the renal system, you're going to probably see decreased urine output starting, or you may see excessive amounts depending on where they are in the phase. Neurologically, they can be very tired acting, muscles twitching. Again, remember electrolytes here. They can have hyperkalemia. They can have hyperphosphatemia. They may have hypo or hypercalcemia. All those things, based on what it is, can cause some muscle issues. Hyponatremia, in particular, can cause seizure activity when the sodium is off. So again, we can see changes in the neurological system. From the integumentary, they may have dry skin. They can have dry mucous membranes. They can have edema with this. One thing that can happen, and you see this more really with chronic kidney disease, is if those kidneys are not filtering well, the albumin will pass through instead of being retained and held onto. And if that is pushed out, that will drop their nutritional status. And people who have low albumin levels tend to retain a lot of fluid. So you may see fluid retention from that as well. Laboratory findings, and I've listed some page numbers here that you can either look in IGI or you can look in your ATI med-surg book as well. Serum creatinine always, will rise. We talked about that, whether it's stage 1, 2, 3. So you'll kind of look at that. You're going to look at the BUN. It will definitely increase. You can see here it says it may increase to 80 to 100 milligrams per deciliter within 1 week of the initial onset. Urine-specific gravity, post-renal types it will be elevated, and pre-renal types it will be diluted. So it just depends on what you're dealing with, okay? Serum electrolytes, your sodium can be decreased in your pre-renal and increased with intrarenal. So again, you may see changes in your mentation with that sodium being affected. They will be hyperkalemic, may retain magnesium as well. They may be hyperphosphatemic, and they can be hypo or hypercalcemic. It just depends on how that body is going to retain it, okay? Hematocrit and hemoglobin, RBCs, typically will start to fall because the kidneys are not producing that erythropoietin or releasing it. So you may see them become anemic, especially if this lingers on for some time. Urinalysis, you may see sediment. They may even have RBCs present, and they can also go into a metabolic acidosis because remember, your kidneys have your bicarb, which is the base part of our acid-base balance system. Just looking at some diagnostics real quick. I don't want you, again, to spend a lot of time going, oh my gosh, I have to know all these because that's not what is on here. This is just on here so that you're familiar with some of the diagnostics they may use for renal issues. So KUB, you may hear that term. It's just a basic x-ray series of your pelvis, which looks at the kidneys, your ureters, or it should be ureters, and your bladder. This is urethra, but it's really your ureters. They may use ultrasound. That can help looking at obstructions. CT or MRI will give them a better picture so they can, again, look for obstructions, can see perfusion if they do like a CTA in particular, as well as tumors. Kidney biopsy they may do to detect if there's a tumor. Is it malignant? They may look to see if there's some immunological type problem within the kidney. Renal scans also help with perfusion. And then they have some nuclear tests. Again, please don't go crazy learning these. I just wanted you to kind of be familiar that these are some of the diagnostics that they will do. It is important you understand KUB because you may see that on patient records. And if you look at that and go, what the heck is a KUB or a cub? You're going to go, but if you really stop and think about it, it's kidneys, ureters, and bladder. Some of the nursing care for a patient with an acute kidney injury. Definitely want to identify and assist with correcting the underlying cause. So if this is caused from an infection, you got to treat the cause. You can try to fix the AKI all you want, but unless you treat that underlying problem, you're just kind of spinning your wheels. Same thing with hypotension. If it's from a cardiovascular event, those kinds of things. So you always have to look at what caused this to begin with and treat that underlying problem. Monitor their central venous pressures. Again, because MAP becomes so important, watch for tachycardia and hypotension because those are indicators, again, that the kidneys may not be getting perfused. Monitor their fluid intake and output strictly. These patients may be on like hourly I's and O's. And so those are the ones where you'll actually see the graduated cylinder in the Foley catheter because these patients typically get a Foley placed, so we have good strict I&O, so we can actually measure per hour what they are putting out. So you measure what's in that cylinder, then you dump it out, another hour, dump it out. So it just is a good way to do a good strict I&O. Review that lab, make sure you know what that BUN, what that creatinine's doing, that GFR, what do those electrolytes look like. Avoid the use of any nephrotoxic medications. Again, like I said, if this patient has infection, you want to treat the infection, but you need to be wary of what kind of medication are you using. The other thing is some patients may need decreased doses of certain medications because they're not going to clear them if the kidneys are not working well. Okay, assess them for manifestations of heart failure and or pulmonary edema because as those kidneys are not working, they're not filtering the water. And so these patients tend to retain water. So you might throw them into a fluid overload situation. So you need to be monitoring them for that. Okay. So pulmonary edema, you may see the shortness of breath. They may have pink frothy type sputum coming up. Heart failure, depending on what size you're dealing with, you'll have different manifestations, but all those things you need to be thinking about, okay? You want to maintain that MAP of 65 millimeters of mercury to help promote perfusion going to those kidneys to help prevent further damage being done to the kidney. Further nursing care, you may have to restrict fluids as prescribed. They may also give a challenge. Like I said, sometimes they'll do that. But if the body is retaining fluids, you're probably going to need to put them on a fluid restriction so you don't throw them into heart failure or flash pulmonary edema. You're going to have them on telemetry, checking for dysrhythmias and any kind of changes. Monitoring that daily weight because they tend to retain fluid, and that's also a good way for you to understand how well those kidneys are functioning. Assess for any changes in urination. Maybe they've had very little urine and all of a sudden they start dumping urine. And that makes you go, okay, have we gone from oliguric phase to our diuretic phase? Treat infections promptly, okay? You don't want to increase any risk that that kidney can be further damaged by increasing metabolic demands on the body. Good skin care, again, to prevent injury and to prevent infection. Provide psychosocial support, because this can be very scary for people if they've never had a kidney problem and suddenly, because they've had a heart attack or whatever it is that has caused that kidney to be affected, and now suddenly their kidneys aren't working really well, the first thing most people think is, oh my goodness, am I going to wind up on dialysis? So making sure they understand that this is an acute kidney process, you're doing everything to help restore the kidney function. It may just take a while, but the goal is that we will restore it to its pre-event state, and there will be no need for dialysis. Making sure the family and the client understand about treatment. Now, sometimes these patients may need continuous renal replacement therapy during parts of this, which is similar to dialysis, to help treat the kidney, to remove every bit of the waste and stuff like that, because they need to manage that. And then again, just teaching them good coughing and deep breathing. Um, because again, you don't want to wind up with a pneumonia because they're just laying there because they're lethargic and tired and stuff like that. So you still have to think good pulmonary hygiene for these patients as well. So looking at nutrition. Nutrition is very important, and it gets a little tricky when we're talking about dialysis patients. So usually we have dietitians to help us calculate how many calories, how much protein they need to have, potassium, all those kinds of things like that, how much fluid they can intake. So they tend to be consulted for helping with us to calculate all those nutritional needs that the patient has to have. They may have to implement potassium, phosphate, sodium, and magnesium restrictions, or they may have to add sodium in. It's just kind of one of those things, but you still have to remember fluid retention and sodium's effect. So really, it's a very kind of balancing game that you have to play with this. Now it says here high protein may be needed to replace high rates of protein due to the stress from illness, but we have to remember that protein breaks down. It may increase creatinine. It can affect their BUN. So a lot of times they have some kind of restriction after the initial illness um, because we don't want to add to the creatinine in that BUN. You can see down below, I gave you some ranges. Again, I don't want you to like go crazy here, but if you notice, it says no dialysis. It says 0.6 milligrams per kilogram or 40 grams per day, roughly. If you look at for dialysis, you'll see that those numbers go up quite a bit, even can double the amount of protein. But you have to remember that these patients will be on dialysis, so that stuff will be removed. And when I think of those numbers, I think about this more for terms of a CKD patient more than an AKI, but they still may have protein restrictions or additions depending on what is going on. They may have to be on TPN. Iggy does address some of the nutritional therapies in there, and then also you have some renal disorders discussion in your ATI nutrition book that you can kind of look over. You do kind of need to be familiar with what kind of diets your renal patients need to be on, because I could see that being on NCLEX. Looking at some of the pharmacology, they may use IV fluid therapy, like I said, as a challenge. That's usually like 500 to 1,000 milliliters. The ones I've seen are usually 500 over an hour, and then they may repeat that. That's how they get that 1,000 in. And that, like I said, is just kind of kickstart or try to wake that kidney up. And they may use it as well if the patient is on a diuretic type phase. They may use diuretics to promote that increased filtration of the blood by the kidney. And you might see them order Lasix like 100 milligrams, like doses you don't typically see, and you just kind of go, what? But yes, they will do that. Do keep in mind, if you have to give 100 milligrams of Lasix, you must give that very slowly. Those big doses are where you really run the risk of affecting the patient's hearing. So you may need to be prepared to stand there and push that over 10 minutes. So yes, we will use diuretics when we're talking about renal failure. Um, as far as other medications, you do need to check your ones that are nephrotoxic. I feel like I've already talked about this. They may use calcium channel blockers um, to, like it says here, prevent movement of calcium into the kidney cells and maintain cell integrity and increase your GFR. For hyperphosphatemia or a high level of phosphorus in the body, um, they may have to administer um, phosphate binding agents such as calcium acetate or Foslo. That's actually a big thing in people who have renal problems. So it's not uncommon to see them on some kind of phosphate binding agent. I know it talks about it in your ATI module as well. I would tell you you need to be familiar with that. Again, I have seen several questions on giving that medication to patients who have renal issues, whether it's an acute kidney injury or CKD, because you will oftentimes see them on some kind of phosphate binding agent. Additional pharmacology used in the treatment of AKI. They may give sodium polystyrene sulfonate or K-oxalate or sorbitol to help bind up that excess potassium, and this usually occurs in the intestinal tract. So with these, you want to monitor their to make sure they're having bowel movements because that's how they're going to get rid of it. In an emergency with hyperkalemia, you may see them give IV dextrose, insulin, and calcium. This is a protocol you do need to be familiar with. The calcium gluconate itself is generally used to help stabilize the cardiomyocyte membrane because with that hyperkalemia, it can be hyperexcitable. So you have to kind of stabilize that cardiac membrane. And then you'll give the dextrose because you're going to give insulin. Insulin will actually bind with potassium to be excreted, but I wouldn't give insulin to somebody, if my blood sugar is normally 100, I'm not going to be dumping a bunch of IV insulin in them without giving dextrose. I wouldn't even do that with a diabetic after time, even if you guys think about DKA. Once that glucose hits 250 in an insulin protocol, you're having to give dextrose. So it's not an uncommon protocol to give the calcium, the dextrose, and the insulin to somebody who has hyperkalemia to help bring that down. So definitely be familiar with using those three things when you are trying to bring down potassium, okay? And then we also may have to give sodium bicarb to a client if they have severe acidosis, that metabolic acidosis, which can occur with patients who have acute kidney injuries. Further therapeutic um, procedures you might see is hemodialysis, peritoneal dialysis, continuous renal replacement therapy, which is probably the one you're most likely to see with AKI. These do require a consultation with nephrology services so they can actually prescribe what they want. If you've been with dialysis, you know that each person has kind of a dialysate that is chosen for them, that especially with components for their particular level of disease. So important to understand that. We're going to talk about this more in our skills lab, so I'm not going to spend a lot of time talking about hemodialysis and peritoneal dialysis at this time. Renal replacement therapies used for patients with loss of kidney function and inadequate waste elimination. So they're retaining waste products, potassium super high. We have to get that all cleared out. So some of the indications for this is symptomatic uremia, where those byproducts are so high at this point that they're causing issues with the heart, neuropathy, decline in their cognition. They're having persistently high levels of potassium. They may have severe acidosis. We are seeing a lot of fluid overload, which can affect the ability for tissue perfusion. And also If a patient comes in with drug or alcohol intoxication where those levels are incredibly high, they may do CRT to help remove or get rid of that excess amount of drug in the system. They do require vascular access to be achieved. For patients with AKI, they're not going to come in and, unless they are chronic kidney issue patient that already has a vascular access device like a fistula or a graft that's placed in their arm, they're probably going to have a temporary line placed, like a Maherker or something like that. That's usually placed up like in the neck area. And then if it needs to be changed, they can go to a more long-term access device. The patient, how do we help prevent this? Drink at least 2 liters of fluid daily. Again, you still need to check. I'm not going to tell my patient this. If they are a heart failure patient with an ejection fraction of 20%, I'm not going to tell them to drink 2 liters. But typically, for a normal, healthy adult, 2 liters of fluid is a good number for us to consume. Maintaining a healthy weight. Stop smoking. Yes, it does affect your kidneys as well. Use of NSAIDs and other prescribed medications cautiously, depending on what those meds are. NSAIDs do get processed by the kidneys, so don't continuously take 800 milligrams of ibuprofen 3 times a day for weeks and months and years on end, because you will eventually cause some damage to your kidney if you do that. Control diabetes and hypertension. That does affect how well that kidney is perfused. It does affect how well it will function. Diabetes and hypertension are 2 leading causes of chronic kidney disease, so that's why it's so important that we control those disease processes. And also instructing the patient to take all that antibiotic if they have a urinary tract infection, pyelonephritis, glomerulonephritis, whatever it may be. If they're on an antibiotic, it's so important to continue that and finish it all. And I said those when I'm thinking about the urinary tract system, but really an infection anywhere, because it can lead to sepsis, which can then eventually end in a AKI. So you guys should know that anyway. Anytime a patient's on an antibiotic, you tell them to complete the course. Chronic kidney disease, which is a progressive, irreversible kidney injury. So unlike AKI, which we hope we can prevent, um, reverse all that and have the kidney return to its normal state of function. That is not going to happen in a CKD patient, okay? In the early phases or stages of this disease, the client may not even be aware because they may be asymptomatic. So some terms associated with CKD that you may hear used, and I'm going to talk about these in the next few slides, are azotemia, uremia, and uremic syndrome. Sorry, there goes my dog again. So looking at azotemia, this is strictly the retention and buildup of nitrogenous waste products in the blood. So this is like urea, creatinine, ammonia, and uric acid. And I've kind of broken this down a little bit. Urea is a breakdown further of the ammonia, and uric acid is a breakdown of purines. And that's sometimes when we talk about renal diets, we talk about limiting the amount of purines in the diet because of how it breaks down and causes uric acid. It's another reason why when we are dealing with people with gout, we have to be careful if they have recurrent gout over and over and over again, that eventually may lead to some issues within the kidneys. So some signs and symptoms for this, they are generally milder, okay? They may have that reduced urine production, little or no, depending on what phase they're in here. Confusion, decreased alertness that progressively gets worse. Again, think about the electrolytes that are being affected when we have renal problems. And again, now we're talking about chronic people, not acute, okay? So it depends on what stage they're going through here. Thirst, especially if they have like hypernatremia, they may feel more thirsty. Edema, they're going to tend to want to retain fluid. Abdominal pain or discomfort, again, from the retention of fluid. May have a rapid pulse, okay? Dry mouth and increased urination at night. And if you think about a heart failure patient that has fluid retention, especially of the lower extremities, and the feet are down all day, that fluid or that edema starts to pool. When the feet go up at night, whether it's up in a recliner or they're laying in bed, that fluid is then taken up and then it is excreted. So that's why you may see increased urination at night. Uremia, which is like azotemia, but the symptoms are more severe. Okay. Um, you have a raise in the blood levels of that urea and those other nitrogenous compounds. So those things that we talked about, the ammonia, the uric acid, the urea, ammonia, all that stuff is going to start going up. So you're going to see more severe symptoms. These people may complain of things tasting metallic in their mouth or just have a metallic taste in general. They can have difficulty eating. They may have nausea and vomiting, which again makes it difficult to eat. Can start seeing more muscle cramps. And again, think about the electrolyte shifts that we're going to have going on. They can develop uremic frost, which I have a picture, I think, of that on another slide, and you see that typically with uremic syndrome, which we'll talk about again on the next slide. Itching because you may have some like uremic, how do I want to say this, some uremic dry on the skin, so it makes the skin kind of itchy. More fatigue, more lethargy. They may develop hiccups, more edema, more dyspnea, again, because they're hanging on to the fluid. And then you can see paresthesias. Again, this can be related to the changes in those electrolytes. Syndrome. And this is usually a terminal manifestation of kidney failure. So this is something you would see people very end stage renal disease. It says here it's a clinical syndrome associated with fluid, electrolyte, and hormone imbalances and metabolic abnormalities, which develop in parallel with deterioration of renal function. So as that kidney function goes down, all those problems become more and more severe. Okay, so some of the signs, abnormal diagnostic findings. So you're going to see all those electrolytes out of whack. You're going to see that creatinine very elevated. BUN is probably going to be very elevated. That GFR is going to be very down. Again, you're going to see nausea, vomiting, less of appetite. They're going to lose weight because of that, although they may be retaining fluid. So it's going to be very hard to see that. They can have changes in their mental status. Again, keep in mind that sodium can go up or down, so that can affect that. They can have that uremic frost develop, and you can see this on the gentleman's mouth in this picture, all those little white crystals. That is uremic frost, and that's all caused from excess uric acid and stuff like that in the body. And that's why they get that itchy skin. Abnormal bleeding can start to occur, as well as heart issues, whether it be from the fluid retention, putting excess stress on the heart, leading to heart failure type issues, or developing heart dysrhythmias due to those electrolyte imbalances. Okay, and then looking at some physiological changes associated with CKD, and we're going to kind of go through the different body systems here a little bit. So renal changes, I think we've talked about that a lot. Metabolic changes, we're going to see that urea and creatinine levels go up. Electrolyte changes, sodium. Like I told you, in early CKD, you'll see the sodium drop. As the nephrons become less and less able to resorb that, you'll start to see that the sodium is higher and higher because it's not being excreted like it should be. Potassium levels are going to go up. Acid-base balance, again, we're going to lose the ability to excrete the acid and release the bicarb. So you're going to see more and more like metabolic acidosis type things. Calcium and phosphorus, usually the balance is, these two work in reciprocal typically of one another. So when phosphorus goes up, calcium typically goes down. In this case, phosphorus is not going to be excreted, so it's going to be held on to. So you may see that calcium start to drop in patients with CKD as well. And don't lose sight of the fact that this affects muscle function and those kinds of things. So looking at cardiac changes, hypertension, which makes sense. I'm starting to retain fluid and sodium. So I'm kind of in a fluid overload state, okay? I also have dysfunction with that RAS system. So not uncommon for them to become hypertensive. Hyperlipidemia, see changes in fat metabolism. So you may see those lipids start to go up, which great. Now I've got hypertension, which puts extra workload on my heart. Now I'm not getting rid of lipids like I need to, which increases my risk of cardiovascular disease. And I'm also at a higher risk for heart failure due to the increased workload of that heart. As I put that excess amount of fluid in the system, I have hypertension, which changes that afterload, right? It's got to push harder to get past that hypertension and that fluid volume overload. I have anemia, so things are not getting perfused as well. So the workload on the heart becomes excessive in patients who have CKD. So they are at a great risk for developing heart failure as this disease continues to progress. They're also at risk for pericarditis due from inflammation, as well as that uremic toxins that are floating around, or their risk because they're at a higher risk for infection. They may develop some pericarditis, which is inflammation in the pericardium, okay? This may cause you to hear a pericardial friction rub, and I have written down here what that sounds like. It's kind of a scratchy grating or rubbing sound that occurs when the inflamed pericardium rubs against the heart, okay? It's usually heard best at the left lower sternal border, and it may be transient or it can be persistent, so it may come and go, or it may be there all the time when you're listening to it when you're doing an auscultation of the heart. Further changes here. Hematologically, I feel like you guys should know this by now. Anemia can definitely occur in patients who have kidney disease, especially CKD, because of that erythropoietin not being secreted to help maintain the levels of RBCs that the body needs. Like I said, they're the ones that kind of kick in and tell you to do that. So if you don't have enough of that, you're going to be anemic. So some GI changes that can occur, halitosis or bad breath. They may develop tender or sore spots in their mouth. That's what stomatitis is. Already talked about anorexia, nausea, and vomiting. They can also get hiccups, which I found very interesting. And this all really has to do with the dysfunction of the kidney not being able to clear those toxins and that uremia occurring. And what that does is it aggravates the nerves that control your diaphragm, and that leads to hiccups, which I thought to myself, why on earth do they get hiccups? So I found that kind of interesting when I read about that. Peptic ulcer disease is something they might have. Uremic colitis with watery diarrhea or constipation. They can develop bloody stools as well. Cognitively and functionally, you may be asymptomatic in the beginning, but definitely can progress to affect their cognitive and physical impairment. And they may also be more prone to drug toxicity because, again, kidneys are not working, they're not filtering, so they're not getting rid of that excess amount of drugs that the patient is getting. So you always have to be monitoring for drug toxicity. Especially when I'm thinking antibiotics, looking for drug toxicity, I think of narcotics, worrying about drug toxicity. These patients may have to be Narcaned, that kind of stuff, because they're not clearing that drug out of their system. So just some things to think about when you have a patient with CKD. Look at some of the clinical manifestations, and some of these are going to be similar to what we saw in our acute kidney injury patient. Neurologically, they can be lethargic. They can have tremors. Again, think about those electrolyte disturbances. Ataxia, which is difficulty with movement. Okay. They can have seizure or go into a coma. Again, I'm thinking when I hear this, I think a lot of times about sodium, because sodium really does affect your neurological system. But also keep in mind, potassium, calcium really affect muscle movement, so you can see why tremors, ataxia, and that kind of stuff comes in here. Cardiovascular wise, we've already talked about hypertension. We've talked about dysrhythmias with the ECG changes from hyperkalemia, but also Jugular distension. If we were in class, I'd probably ask you, why would you see jugular distension? But if you think about the fact that these patients retain fluid, so they get a fluid volume overload, it would make sense that you will see distension of that jugular vein when you're doing assessment. Respiratory-wise, you may see yawning, shortness of breath. They may be breathing fast. They can have those Kussmaul respirations. Again, they're in a metabolic acidotic state, so they may start to do that. You can hear crackles in their lungs. You may hear a pleural friction rub instead of a pericardial friction rub, as well as that pink frothy sputum, which is indicative of pulmonary edema. I really want you guys to understand, if you see pink frothy sputum, NCLEX is trying to get you to understand that these patients have pulmonary edema. So just always think pink frothy sputum, pulmonary edema. Hematologically, you're going to see signs of anemia. So they're going to be pale. They're going to be tired. They're going to have dizziness if they do too much because they don't have good oxygenation, because they don't have enough transporters for the oxygen. They may also have tachycardia because of low hemoglobin. They may be short of breath because of low hemoglobin. So think about hematologically when you think of renal patients having issues, that they're going to be anemic, and what do you see in an anemic patient. So I hope you're kind of seeing multi-system wise how all these systems fit together and all these changes you can see simply because the patient has chronic kidney disease. Looking at some further clinical manifestations, GI and skin we've already kind of talked about, with the nausea and vomiting, the itching, and that kind of stuff going on. Skeletal wise, you can see some osteodystrophy, which is a fragile, thin bone. If you think back to what the kidneys do, helping absorb vitamin D, which helps with calcitrol, that's why these patients run the risk of having thinner bones, okay? Urinary wise, changes in their urine, the color, concentration, contain a protein. In fact, with AKI, that's one of the things you look at. Are they spilling protein into their urine? And it makes sense. The more concentrated, the darker the urine's going to be, kind of like that dark tea kind of thing, okay? Some lab tests that you may see with this. UA, you may see blood in the urine. Protein, already kind of mentioned that. Decreased specific gravity because the kidneys themselves cannot concentrate that urine anymore. Serum creatinine gradually will increase over months to years. With CKD, it says here exceeding 4 milligrams per deciliter, but can increase to as high as 15 to 20. I've never seen it that high, but that's what they say it can get to, and I believe it. I have seen it as high as 10. BUN, gradual increase again. Same thing as with your serum creatinine, and can increase to 100 to 20 times the creatinine level that you're seeing. 24-hour creatinine clearance test. This is a urine test that somebody will do usually at home. If you've ever had to do one, they urinate the first time, they don't save that urine, and then from that moment on, they start saving their urine for 24 hours. Every time they go to the bathroom, they put that in a jug. The jug needs to stay in the refrigerator. Once they're done with it on the next day, they bring it back in, and then they check it to see how much creatinine they're clearing in that 24-hour period. And then also looking at a CBC, chemistry panel should probably be on here too, but looking at a CBC, we're going to see decreased hemoglobin and hematocrit. And again, with a chemistry panel, you're going to see those changes in the electrolytes that we've talked about. These should all look familiar because they are the exact same diagnostics we had with AKI, so that doesn't really change. They're going to do that KUB, they may do an ultrasound, CT, or MRI, or that could be like a CTA where they're actually doing angiography, so they're looking at blood flow. It may do biopsy again, as well as some of the nuclear testing. About nursing care as it relates to a client with AKI. And I have given you some page numbers here, your MedSurg book, page 436 through 437, and also an IGI 1471 through 1476. I like how ATI really puts this out. It's very bulleted, it's very simple, it's easy to understand. So with your CKD patients, just like with your AKI, we're going to monitor urinary output patterns, okay? Monitor those vital signs. Keep in mind they're prone to hypertension. Eyes and nose, okay? Their weight, Remember, they're retaining fluid. I have to watch that. So weight, just like with CHF patients, daily weights become a very important part of your assessment. I think sometimes it's really easy because we do eyes and nose vital signs all the time and we weigh people that we don't really stop and think about the importance of doing those very simple things because we always want to go to complex, but those very simple things are very important when you're dealing with patients with retention issues. So, and report any irregular findings. So if your patient weighed 120 today and they weigh 130 tomorrow, that's a pretty significant finding that needs to be addressed with the physician because obviously we need to pull that fluid off. Constantly going to be monitoring those labs. Assess for any signs of heart failure. Monitor them for pulmonary edema because that's two of the things they're really at risk for. Collaborate with dietitians for enhanced nutrition. I'm thinking with this as well, you're going to collaborate with your nurses who are responsible for doing dialysis because they're probably going to be the ones that are going to come in and do that for you. Always want to prevent infection because that puts extra stress on the body and can cause the kidneys to function even less than what they're doing. Educating them on maintaining the diet restrictions that you had them on, fluid restrictions that they may need to have, on taking those medications, dialysis schedule. Usually for somebody who's on dialysis, they do dialysis 3 days a week. It's usually a 4-hour exchange time. So that is very daunting and very psychologically down for a lot of patients when they realize they're going to be tied to something like that. You think about it and not being able to go on vacations, or if you do go on vacations, it's all setting that stuff up at facilities that you're not used to going to. So it's really psychologically, it's a pretty good, I shouldn't say pretty good, and it's just a pretty good um, disease process that kind of messes with you. I think anytime you have a chronic debilitating illness, it kind of does that. But even with some of the others, you still have the ability to leave and go places. People who have CKD who are tied to hemodialysis, it becomes harder and harder for them to do that. So don't forget about those psychosocial needs that they may have. Um, if you did the module in ATI on the renal system, and really you just needed to listen to, I did like the anatomy and physiology stuff, and then I went down and did the acute kidney injury and the CKD. And on the CKD, they have a little podcast, and they actually talked to a gentleman who has had to do um, dialysis as well as change his diet. And he talked about trying to get used to not being able to drink that much. That was really hard for him. So I like that they just gave you a human perspective of what it's like for those patients. So if you haven't listened to that, I encourage you to do so. Some of the nutrition, you're going to see some of the same things we saw for AKI. So some restriction on their dietary sodium, because keep in mind as the kidneys become more impaired, they're not going to filter that sodium, so they're more likely to have hypernatremia. They're going to have to restrict their potassium. They're going to have to restrict their magnesium and their phosphorus. Now, one important thing to note here is if I tell them they have to restrict their sodium, a lot of people want to go, hey, I'm going to do a salt substitute. No, because I'm having to restrict potassium. So with patients who have kidney problems or have to worry about restricting sodium and also restricting potassium, you need to, encourage them to find other ways in which to season foods. There are all kinds of different things out there that do not contain sodium that use different like spices and herbs to make things taste better. And that's where your dietitian can be very helpful in creating a diet plan for them. Protein restrictions, especially early on in the course of the disease, to preserve that kidney function. It's really based on the degree of how well that kidney is functioning, what kind of restrictions they need to do. So again, working with a dietitian to help them calculate that is probably one of the best things that you can do. Okay, those do change once the patient starts dialysis. Usually they will start being able to consume more protein because they need it because of the dialysis and because the dialysis is going to help filter that out. Okay. I know I've had students before that were dialysis techs, and they said they tell their patients just eat all the protein you want. And that's great, that's real world. But in the world of NCLEX, we don't just say, hey, protein out because you're going to dialyze it. They still will have some restriction, just so you know that. So if you see that in dialysis, know when you're testing, that's not your right answer. When you're testing, they still have some restriction, but they still require more than somebody who is not on dialysis. Okay. Provide a consistent carbohydrate and moderate in fat diet. They will need to restrict their fluid intake, especially as the disease progresses again. And cannot stress enough having them consult with dietitians to help them manage their nutritional needs. I mean, we have basic knowledge of nutrition, and that's all we're supposed to have as nurses. But these patients typically need much more information than we can give them, unless you're somebody who works in dialysis a lot, you're somebody who is like maybe dialysis certified. You may not be able to give them all the information that they need. So that is something that you may want to look at. The last line on the presenter notes talks about BUM serum prealbumin levels are used to monitor the adequacy of the protein intake. So decreased serum prealbumin level indicates poor protein intake, and that's true for anybody. We'll do that when we're looking at nutritional status. We'll look at albumin and that prealbumin. So just something to kind of, think about. We're going to talk about pharmacology, and wow, look at all of these kind of sound the same. So we have sodium polystyrene again to decrease potassium. Um, the apotin alpha, or that's the erythropoietin, to help with the anemia issues. Ferrous sulfate, or an iron supplement, they may do that as well to help prevent iron deficiency. Calcium acetate, that is the phosphorus binder. That's like that Foslo that we talked about. And then we have calcium carbonate, binds phosphate as well in foods and stops absorption. So we're kind of giving some information here. If they're taking calcium carbonate, they can take it with meals, take 2 hours after other medications, and this one can cause constipation, so they do need to have stool softeners with that. And something we didn't really talk about much, but it can also, with renal issues, can elevate their serum magnesium levels. So they need to avoid taking antacids that contain magnesium. So they can use aluminum-based formulas instead. Don't want to use magnesium. And then I did list a page number here with some for explanation of medications if you want a better understanding of them, which I think understanding your farms also, it's a good thing to know that. So some pharmacology continued. Again, furosemide are using some kind of diuretic to help get rid of the excess fluid. We do avoid giving them in end-stage disease, but they can also use thiazide diuretics, potassium-sparing diuretics, and osmotic diuretics. So, I think potassium-sparing, that would be like spironolactone. Your thiazide diuretics would be like HCTZ, that hydrochlorothiazide, and an osmotic diuretic would be like mannitol. So they may do those instead of using like your loop diuretics, because if you think about loop, is in the loop of Henle, and that goes through the kidney. But they tend to want to give something to help get that excess fluid off. Avoid giving antimicrobials, NSAIDs, ACE inhibitors. ARBs are those angiotensin receptor blockers, contrast dye. All of those things can be nephrotoxic. It's not uncommon for patients to be put on ACE inhibitors and ARBs, but as the patient progresses and that CKD gets worse, stage 4, stage 5, you see here where that GFR is below 30, those medications will typically be stopped, okay, because they have negative impacts on that GFR. And then you also need to monitor medications that have therapeutic indexes. So I think of things like DIG, lithium, vancomycin, those kinds of things. Bank would probably not be a good drug for them anyway because of its impact on the kidney, but you do need to monitor them very closely because you may have to give lower doses, like I said, because they will not excrete it. So they're much more likely to have toxicity issues with drugs if they have CKD, especially if it's progressed. So some health promotion and disease prevention. You're going to see some similar things to what we saw with AKI. Again, drinking the 2 liters of water. Again, as the disease progresses, that will then become a restriction and not an encouraging, okay? Limit alcohol intake, stop smoking, adhere to medication guidelines to prevent any further damage. Clients with hypertension and diabetes should have their urine checked for albumin. Um, Take all their medications until completed, like prior. Limit over-the-counter NSAIDs because they are metabolized and excreted, I should say, through the kidneys. Use diet and exercise to help maintain a healthy weight. This can also help with their diabetes management and their hypertension management. And we do know, like I said, hypertension, diabetes, two of the leading causes of CKD. So if they can learn to control those disease processes, hopefully we can slow down the progression of their CKD. And again, looking at treatment options with renal replacement therapies. We will talk more about these in Skills Lab. These are needed when pathological changes occur and the patient is stage 4, stage 5, or there are life-threatening issues at hand. Typically, they wait till they're stage 5, not always stage 4, to start dialysis. Um, like it says here, can also use them with AKI, which we've already talked about. We have hemodialysis versus peritoneal dialysis, and I've listed some of the different types of peritoneal dialysis. Please do not go like diving into all this, whether it's continuous ambulatory peritoneal, continuous cycle peritoneal, automated peritoneal, all that stuff. Don't, that just is talking about the exchange times, dwell times, those kinds of things. I don't really care that you know all the different ones. I will talk to you guys in class about hemodialysis, some of the risks, um, the access device kind of things that they use. Same thing with peritoneal dialysis, the risks associated with all of them. But you don't have to um, be an expert on this. So keep that in mind. Don't go off the deep end trying to learn all those different ones. I just wanted you to know there are different types of exchanges when you're doing peritoneal dialysis. Look at the next step. So if the patient has CKD, it progresses, they are receiving dialysis, and things are still not going well, eventually they may get to the point where they're looking at kidney transplant. And this can definitely improve the quality of life of the patient with end-stage kidney disease because they will no longer be required to go to dialysis 3 times a week. It is important that the recipient's tissue match that of the donors. We do not want rejection. So they will do in-depth tissue testing, including that ABO compatibility and incompatibility, just like we do with blood. They will also do HLA, which is that human leukocyte, let me get it out again, human leukocytic antigen, and then they will also look for other minor antigens. If you're familiar with that, you know that one of the first things they ask you is what type of blood you are. And then they do further testing. So you can still have the same blood type, but not be a good match due to those other antigens that they have to match. To the whole point of that is to prevent rejection of the organ. Donors can be live for this one because you have 2 kidneys, so you can actually give one of your kidneys to somebody as a live donor. You can have a non-heart beating donor, which just is exactly like that. The heart has stopped beating, or what they call a cadaver donor, which I think of this sometimes when you have patients who have, let's say, a serious head trauma. They decide that there's no more brain function, but all the organs are still working well, including the heart. That is like a cadaver donor. some of the pre-procedure care from a nurse. And the one thing I didn't mention, there's actually a chapter in your ATI book, chapter 60, that goes over this, and I just kind of pulled some of the information out. But I do encourage you to look at chapter 60 because there will be information on your test regarding this stuff. So usually, if a patient is going to have a kidney transplant, they'll usually have them do dialysis within 24 hours of having surgery. Preoperative labs, they'll do a chemistry panel, they'll do a CBC, they'll check a urine culture because they don't want them having, any kind of infection when they're going to do this. Plus, they're going to look at protein and stuff like that. They will do a coag panel where they're going to test clotting times and those kinds of things. And then they will do a blood type and cross match because this patient may need blood once this procedure is done because the risk for bleeding is quite high. Preoperative medications, they will probably give them some kind of prophylactic antibiotic, and they may start them on immunosuppressant therapies to prepare for the kidney transplant. And these are medications that the patient will probably have to be on, I should say, they will be on post-transplant to decrease the risk of rejection. So they use things like corticosteroids, cyclosporin, they'll use these mammalian target inhibitors, and then monoclonal antibodies. And so some pre-education with them is making sure they understand the importance of adhering to the immunosuppressant therapy, because if they come off of that, there is a chance that the body will start rejecting the organ because the immune system will recognize it as foreign and try to attack it. And then also just the mental and emotional preparation for the procedure. I'm sure there's a little bit of grieving that goes on when you lose your own body parts. And then you stop and think about if you're getting cadaver donor, somebody has had to die for you to get that kidney. If you have a friend that decides to donate their kidney to you, I'm sure that's a little emotional too. Like, what happens if something happens to them and all those things? I'm sure all those different emotions come into play when you're going through transplant. And then looking at some of your post-procedure frequent vital signs, and I know it talks about this in your book. I want to say it was like every 15 minutes for so many times, and then eventually you go to hourly. Same thing with I&O. Hourly I&O, and that makes sense. I need to make sure, is that kidney working? Once I transplant it in, is it starting to function and is it starting to produce urine? I just recently watched a show on TV. It's a documentary, and they were transplanting a kidney. It was actually a live donor, friend of the gentleman who volunteered to do this anonymously. The other patient did not know that his friend had done this. And they transplanted it. They put a Foley in place because they need to know how much is actually coming out. And before they even took him to the recovery room, the kidney was already functioning and starting to produce urine in the catheter. So it was kind of cool to see that. Again, they'll be daily weight because I want to check for retention and all that kind of stuff. They're going to be monitoring their labs, looking at their fluid levels, that electrolyte balance, monitor for signs of infection, which you would do with any kind of surgery patient. Provide catheter care because, yes, they will have a Foley, so you can do that strict I&O. Last thing you want is for them to get a CAUTI because you didn't do Foley care. That maybe might be the reason why they get to keep that kidney or not. You're going to administer those anti-rejection meds. Monitor for early signs of rejection, which could be fever, hypertension, pain at the transplant site. And on the next slides or so, we're going to talk about transplant rejection. And administer fluids and encourage their PO intake because you want that kidney to be able to start kicking in and going. So I wrote on here that your full list of post-procedure care can be found in your med-surg book, in your ATI med-surg book, page 426. Types of rejection. We have hyperacute, we have acute, and we have chronic. So a hyperacute reaction occurs basically immediate, like it's an immediate thing or within the first 48 hours of surgery. So you might see widespread clotting, you may see tissue necrosis, which basically leads to massive cellular destruction. So some of the things that you will see finding wise are that fever, hypertension, and pain at the transplant site. That's why you monitor for those things. With a hyperacute reaction, the only thing that you can do is remove that organ. Okay. They just have to take it out because it's just not going to work. It's only going to sit in there and necrose and cause infection and further problems. So this patient would lose that kidney and go back on dialysis. Okay. This does not happen as often due to the fact that they now do that HLA or that human leukocytic antigen testing now on the donor organ itself. But it still can happen. I actually had a friend that did have a hyperacute and had to lose their organ rather quickly, which is unfortunate. They were able to get another one and they are doing very, very well now. And then we have an acute reaction or rejection. This can occur in like up to a year, within a week to 2 years. It's similar to above, but those killer cells enter and also affect the destruction of it. So it's similar to what happens up, it's just a slower process. So manifestations with this would be signs that the kidney isn't working well. So you see decreased urine output, anuria, which would be no urine output, okay? Low grade fever, you may see hypertension again because the RAS system is not in place. Lethargy, you may see signs of azotemia again. They'll start retaining fluid and they may have some tenderness over the site. Now, typically when that occurs, they may up the anti-rejection medications to see if they can try to, um, get it to kind of kick back in or to have it last longer. But they're going to start looking at the probability that this organ's going to be rejected and may need to have another one donated. Chronic rejection occurs gradually over months to years, and basically the tissue is just replaced with fibrotic or scar-like tissue, which is non-functioning, just doesn't work anymore. So the findings are similar to what you saw above. You'll see the azotemia again, fluid retention. You start seeing changes in electrolytes and fatigue, just like you would in your chronic kidney patient. Again, they're going to start showing those same kinds of issues. Again, they may continue with the immunosuppressive therapy, and they will do that until the patient requires dialysis again. And this patient is probably going to wind up having to have a new transplant. The friend that I mentioned that had the hyperacute, that was actually the second time she was having her kidney replaced because they'd gone into chronic rejection, and that's when they knew they needed to start looking for another kidney, and they had to start dialysis before they found one, and then they got that transplant, and then it was a hyperacute reaction, and then had to get another one, but they were able to secure it, and they're doing fantastic now. So again, looking at transplant rejection, management of the transplant rejection, keep in mind that this whole thing is designed to sustain the life of the new organ. So that's why it's really important that they understand that maintenance therapy, that they stay on that immunosuppressant therapy, that it's taken for life. They don't get to come off it at any time. That because they're on immunosuppressive therapies, it will increase their risk that they can get other secondary infections. It can also increase their risk for the development of cancer. If you think back to our oncology lecture in third semester, your immune system does play a vital role in checking mutated cells and getting rid of them. So, that is a risk factor that they will face, and they may have to have closer monitoring. Rescue therapy, this is used to treat the acute rejection episodes, can be used also for maintenance, but at higher doses. I should say they use the same medications, but they give them at higher doses when they're seeing acute rejection starting. They may also use the monoclonal antibodies or the polyclonal antibodies for that as well. And monitor for signs of rejection and contact the provider immediately if you see signs of that occurring. And rejection is diagnosed through kidney scan and biopsy. Again, don't make yourself crazy with transplant rejection. When I think of this content, I need you to understand the difference between a hyperacute, an acute, and a chronic. I need you to understand that these patients will take immunosuppressive therapies that are things like corticosteroids, um, those monoclonal antibodies, different things to suppress the immune system to prevent rejection of the drug. How do you know when a patient's rejecting the drugs? Understanding those little manifestations like fever, hypertension, decreased urine output, tenderness at the site, those kinds of things. And just that the patient understand that this is a lifetime thing that they're committing to with those medications, and there are risks for infection and risks for cancer. So how do I teach them that? You know, wear a mask during flu season. That's probably a good thing for somebody who has had a transplant. Monitoring yourself more closely. If you have a family history of colonoscopy or of colon cancer, you may need to have a colonoscopy more frequently than every 10 years because you're at a higher risk. Those are the things I kind of want you to understand. For this one, really, I just want you to think about some of the legal issues you might see when treating a client with AKI or CKD. You know, what are some ethical things? What are some cultural things? You know, there are some legal issues when you're looking at donors and those kinds of things that we go through. Ethically speaking, um, you know, I know when you're looking at a donor um, or a recipient, you know, if you have a patient, I know for a fact when you liver transplant, for instance, a little bit different, but liver transplant patients, if they have chronic alcohol use, they are not eligible for a liver transplant until they have successfully completed a rehab program and have been tested and proven to be sober for, it used to be 6 months, but it may be a year now, um, where they have to prove they're clean, where they literally have to go in and have a blood test done every month to see if they've had any alcohol in that month. If they have, their time starts over because they don't want to give a viable organ to somebody who is just going to abuse it again. So that may be the case too with like drug addiction and stuff like that. So there are some ethical issues. Culturally speaking, there may be some cultures that do not believe in um, organ donation or receiving somebody else's organs, or I'm thinking about the risk of bleeding with this. Um, you know, you may run across somebody who doesn't want to have blood, so that could become a problem as well. So these are just some things I want you to think about legally, ethically, and culturally. You always need to think about that and how it plays into your nursing practice. I always like to have resources for you guys. So these are some of the things you can find on Khan Academy. Um, on YouTube. I like Khan Academy videos because to me they just help things make sense. So I've just listed some here for you that you might, you know, if you have extra time and you want extra resources, you can use these. These are some additional resources. Again, you all know that I like Nurse Sarah and Registered Nurse RN, and she has both a chronic kidney disease and acute kidney injury videos that do a great job explaining the whole disease process, understanding the labs, and all those kinds of things. I know you can find things with Level Up RN and Simple Nursing, and I do like their videos, but the one thing I always like about Nurse Sarah and Registered Nurse RN is she really gives you the why. Why are things the way they are? Um, Simple Nursing, Level Up, they give you things you need to memorize, which if you're just in a hurry and you want quick like that, that's great. The problem with memorization is you can forget it. If you learn something to understand it, and that's why I like Nurse Sarah, you're less likely to forget something that you understand, because if you understand it, it's in your memory bank. It's not something you just, a few facts you've just crammed in there to forget later on. So you guys can use whichever videos you want. I just tend to really like somebody who explains the whys.